So, autosomal dominant polycystic kidney disease affects all ethnic groups and is the most common monogenic kidney disease with a prevalence of 1 in 500 to 1 in 1,000. That means you might come across at least one case in 500 patients who will present with ADPKD. And we need to know that it's the commonest hereditary cause of end-stage renal disease. That means it's familial, it can be inherited. Even if we have no other risk factors, just having it in the family is going to predispose as having suffering with this disease. So how does it present? So basically it's the development of multiple bilateral fluid-filled renal cysts. And then there are thousands of cysts of varying sizes typically in each kidney, and it presents bilaterally. So the most common presentation would be gross hematuria, proteinuria, hypertension, nephrolithiasis, pain, and larger kidney volumes, and then there can be severe complications. So the way I'm going to summarize for you is a case report that was published in the journal Curious, the details of which I will share at the end of my presentation. This patient presented with ADPKD bilaterally. First, we resected his right kidney. We found it to be a slightly heavier, but it was not unusual. But the left kidney, when it took over the function of the kidney system, then it enlarged to a size that was massive. That was almost 20 pounds. So imagine 6 ounces is a normal size, but this kidney was measuring about 20 pounds. That's really huge. And at a point, the patient did not have any kidneys in his body because we had to resect both of them out because of the complications. And then the patient had to be put on dialysis. And we'll see how the patient presented. So it was a 43-year-old male with a family history of ADPKD. He presented with severe abdominal pain and a sense of bilateral fullness in both legs. Intermittently, he had pain in his lower abdomen, which radiated to his back and pelvis for the last 3 months. He tried to manage the pain with analgesics, but it did not improve. And he complained of low-grade fever. He was very thin-built, averagely nourished, and had obvious pallor. So when we examined him, he was definitely in hypertension. And at the same time, when we did his physical examination, we found bilaterally enlarged kidneys extending towards iliac foci. So initial labs showed mild leukocytosis and definitely low hemoglobin. He was anemic. And his metabolic panel showed that he had high serum creatinine, meaning his renal parameters were deranged. Apart from that, everything was normal. So we can see here the creatinine is 10.9 at presentation with blood urea nitrogen as 45. So what do we do next? Like, we want to find out the cause of his deranged creatinine, deranged kidney function and hypertension. So we decided to do a renal ultrasound. So when we did the ultrasound, we found that both the kidneys, the parenchyma was replaced by multiple varying sized cysts. And a few of the cysts in both the kidneys had hemorrhagic transformation. So we also found some cysts in his liver. So this is an ultrasound here. So the arrows point to the pulsating masses, basically the vascular stalks of the hemorrhagic transformation. You can see the polycystic kidneys over here. So at this point of time, his right kidney was enlarging very rapidly. So we wanted to know the extent and measurements of this kidney. So we decided to do a CT abdomen. So when we did the CT abdomen, we found that the right kidney was measuring 30 into 15 centimeters. This itself was very huge. And then we had to decide that this patient needed a right nephrectomy. So we involved the urology and the team, nephrology, urology, anesthesia. We all decided that this is going to be a very hard surgery. It was actually a very long surgery. It took us 6 hours. And finally, when the kidney was resected, it measured 30.3 into 15 and weighed 9 pounds. That itself, we thought, oh, wow, that is going to be so big, right? Now, like, I'll give you an idea. This is the right kidney. If any of you have an idea how small the normal kidney would be, then you can appreciate that this right kidney is actually occupying all of the right iliac fossa, almost everything. And you can imagine how it can press on the other organs. You can see it's pushing the liver up and the colon down. And the left kidney is still like, growing, but has no space to grow. So after we remove the right kidney, 3 months later, the patient presented with hematuria, fever, chills, and then lab values again showed us leukocytosis, anemia, raised CRP, and his creatinine was now 11.14. So this meant that the left kidney was enlarging way faster than we had expected. And we repeated the ultrasound, we repeated the CD, and then we found out that not only was the left kidney enlarging, it had crossed the midline and it was encroaching onto the right side of the body. So again, the patient had to be taken for a left nephrectomy. So imagine this situation where you're looking at a patient who will now have no kidneys left in his body. So we had to initiate the patient on hemodialysis every day. After we initiated the dialysis, we took the patient for a left-sided nephrectomy. And when we did the nephrectomy, the specimen weighed 19.8 pounds. That is almost 20 pounds. So the gross specimen, you can see it's a huge kidney. You can see the cysts on the surface. It's a bosselated appearance with a lot of necrotic material here, a lot of blood clots due to the hemorrhagic transformation. A cut section will show you that there's more of the necrotic debris. The entire renal parenchyma has been replaced by cysts. So you can imagine this patient had absolutely no kidney function left because there's no functional parenchyma. It's just the cysts. And these cysts were getting infected and having blood collection. There's fat transformation. So what do you see when you look at such a kidney under the microscope? There's something pathognomonic about ADPKD. Of course, it's the cystic transformation. All the cysts are lined with cuboidal epithelium, but there's something called xanthogranulomatous changes, which are sheets of foamy macrophages, cholesterol clefts, giant cells, and collection of inflammatory cells. This is a sign that the cyst is now getting infected, cyst is now enlarging, and basically the kidney is left with no more function. So what is the discussion? What do we learn from this case? So to our knowledge, this was the first case in India reported with the given weight of the resected ADPKD kidney. Typically, ADPKD kidneys are expected to be enlarged more than the normal size, but this was like 20 pounds. And there are only 2 cases reported similarly, but they were outside India, one in Netherlands, and the second was in England. And so this was something surprising for us. If any one of you wants to know what happened after we did the left nephrectomy, well, the patient had to be maintained on hemodialysis. And 6 months later, now, he received a cadaveric renal transplant. He's under immunosuppressives. He's doing well. He needs intermittent dialysis on and off. His creatinine is coming back to the baseline, which is 4 for him, and he's doing well. So the take-home message here is that not only did it involve accurate diagnosis, a systematic approach, giving the patient the care and attention he deserved at the right time, and also having expertise in the procedures like hemodialysis or the nephrectomy. This can bring out very good outcomes. And also, I should say the patient was very strong, had strong willpower, and he did not give up, even though he was so anemic. He received so many transfusions of blood. He was so weak, he was thin, but he did not give up. So that kind of encouraged us also to give everything we had to the patients. At the same time, I would want to add that polycystic kidney disease, as I started off, is not something uncommon. It's not something rare. It is an autosomal dominant disorder. That means even if the patient inherits one allele, he's going to show the disease. It's a multi-system disease. It can involve kidney. It can involve other organs like liver, spleen, pancreas, and including brain. So we have to have a high index of suspicion. If someone is presenting with ADPKD, they can also have cysts in their liver, spleen, and in the circle of Willis in the brain. So ADPKD is the most common hereditary disease. It's caused by mutations in PKD1, PKD2 genes. They're located on chromosome 16, short arm 13. And these mutations are usually present in more than 90% of the patients. ADPKD is the most frequent cause of kidney failure. At least 6 to 8 patients proceed towards end-stage renal disease. In our case, we did not perform the mutation analysis because everything was straightforward. Patient had a history, patient is showing, the specimens are showing definite diagnosis of ADPKD, so we did with the genetic testing. Clinical manifestations of ADPKD is related to the size of kidneys that increase with age and severity. And basically when the kidney enlarges, that's what is causing the problem. So patients have wide range of clinical manifestations like pain, hematuria, vomiting, hypertension, kidney dysfunction, and sometimes it's just because the cysts are enlarging. They're getting infected, they're rupturing, patient is having hematuria and pain. Episodic renal colic is also quite common, and patient, of course, can present in sepsis due to infection of the cysts. Urinary tract infections are common. Nephrolithiasis is also common. And initially, the kidney morphology remains within normal limits, but studies have shown that between the ages of 50 to 70, most of the patients present with progressive renal failure. What happens if we don't treat ADPKD? Obviously, it leads to pressure symptoms, it leads to infections, it leads to end-stage renal disease. At the same time, cerebral aneurysms can go undiagnosed, patient can present with hemorrhagic strokes. So there's a lot that is involved with this disease, even though it's a benign condition, as in it's not a cancer, but the proliferation of the cysts is so dangerous that it can lead to a lot of complications. How do we screen and diagnose ADPKD? The screening and diagnosis are based on clinical presentation, largely the age, family history, and number of cysts in the patient. So we have a definite ultrasound criteria for the diagnosis of ADPKD. I'm going to share the criteria here. So if the patient is 15 to about 29 years, and if there are at least 3 cysts in both kidneys, there's a sensitivity of 81% that this patient is having ADPKD. If it's between 30 to 39 years, 3 cysts in both the kidneys, then it's 95%, 0.5%. You can be sure that this patient is suffering with ADPKD. If it's a patient aged 40 to 59 years, and even if there are 2 or more cysts in each kidney, then we can be 90% sure that this patient has ADPKD. How do we manage? Of course, it has to be managed symptomatically. Have a high index of suspicion for the signs and symptoms. And patients, if they present with pain, they're managed with opioid analgesics. Obviously, you don't want to give them NSAIDs or other typical painkillers because it involves kidneys, so it can damage the kidneys. So we usually prefer opioid analgesics or tricyclic antidepressants in chronic cases. Early management of cyst infection, hemorrhage, and UTI with obviously adequate hydration and antibiotics is important. Definitely proper control of blood pressure. So this patient that we had to control him with 2 antihypertensives at the same time. So you will have to size the antihypertensive treatment according to how the patient is responding. So because let's say even the patient may not have the cystic symptoms or the infection due to cyst or the enlargement, but if we don't control the hypertension, that itself can have an impact on the kidney. So we have to be careful there because uncontrolled hypertension can speed up the renal function decline. Next is how to control the hypertension. Then best is the ARBs and angiotensin converting enzyme inhibitors. So your sartans and your captoprils, all those pril line of drugs and the sartan line of drugs are best working in ADPKD. Several lifestyle interventions can help delay the progression, like dietary sodium restriction, hydration, healthy weight maintenance. So having a healthy lifestyle goes hand in hand. And patients should be educated about the complications and the conditions so that they themselves are aware to detect a few changes if they may experience and come to us as soon as they happen. Another interesting thing is tolvaptan is indicated to slow down the kidney growth and the GFR decline. So it is known to have shown improvement in terms that the cysts do not divide so rapidly or grow so rapidly if the patient is treated with tolvaptan. And of course, if nothing works, and just like in our patient, if nothing works, then we have to have a therapeutic nephrectomy. And sometimes be prepared that just the way my patient had, we would have to initiate the patient on dialysis and keep him on dialysis until he gets a kidney donor. Because for me, in 8 years of my practice, this was the first time I saw a patient with no kidneys in his body and still able to function because we were giving him efficient dialysis, and the patient was also cooperative, and we always had to efficiently measure and be calculative in anything that we did for him. So that is also very important. So to conclude, ADPKD is the most common hereditary kidney disease. It has significant impact on survival and quality of life. Being on hemodialysis, obviously patients do not like that. They have usually it's not because of the condition, but it's because of the feeling of dependency and being dependent on dialysis and the nagging pain and opioids can also be, contributing to the patient's frustration. That's why a comprehensive knowledge about ADPKD, including genetic heterogeneity, phenotype variation, accurate diagnosis and management. Early diagnosis management is essential to prevent the complications of ADPKD. And of course, lifestyle, medications, surgical intervention is the mainstay. So this case report has been published in Curious. The details are as follows, and I share the authorship with Dr. Jyotsna Gutikonda, and whoever is interested can refer to this case report over here. And these are my references. I have a few acknowledgements: Dr. Jyotsna Gutikonda, Dr. Srinivas, Dr. Tagore, Dr. Zahur Ahmed, Dr. Tajuddin Khan, and Dr. Sirajanisa. They are my parents. Without these people, I couldn't have put this case report together. And please feel free to ask any questions that you may have, or even if you don't get a chance to ask me now, you can email me at drsahershizattaj@gmail.com, and I'm ready to take